Well, good day, everyone. Thank you for being here for today's webinar. We are looking forward to hearing this presentation from Dr. Talbot. At the end of this presentation, we will have a question and answer portion. So if you have a question throughout this presentation, please put it in the chat or QA and we will try to get to it. For now, I have the pleasure of introducing our guest host, Dr. Brett Talbot. Dr. Brett Talbot is a licensed psychologist with extensive experience in executive clinical roles at behavioral healthcare organizations. Dr. Talbot is a CCO and co-founder at Videra Health, a digital healthcare technology company with a focus on AI-powered video. Dr. Talbot, co-created the PHQ-V, the GAD-V, and PCL-V, which are video-based AI clinical assessments. His research has demonstrated the accuracy of these assessments in detecting depression and anxiety, even when traditional methods have failed to do so. Dr. Talbot speaks nationally on many topics, especially on the application of AI in behavioral health. He is also a member of the Conference Planning Committee for the Informed Artificial Intelligence Conference, the largest AI business conference. Dr. Talbot also serves on the BestNotes Advisory Clinical Board, where he supports us with clinical quality assurance and cutting-edge outcome tracking techniques. Dr. Talbot, thank you so much for being here. We are very much looking forward to your presentation. Please take it away.
Thanks, Nicole, and thanks for saying all those nice things that I sent to you to say about me. It's definitely a pleasure to work with BestNotes and all the great work you're doing there. And I appreciate and privileged to get the invite to talk about this topic on this webinar today. We will be talking about using AI, particularly in behavioral health, and particularly how to leverage video and voice analytics. As Nicole mentioned, if you have questions throughout the presentation, please drop those in the chat. I'll do my best to answer those as we go. Otherwise, we'll definitely have some time at the end to have some questions and answers. Quick overview, we'll kind of overview a little bit of what the industry is and landscape in AI, some of the emerging solutions around voice and video AI, and then really the bulk, I want to focus on the applications of AI in behavioral health. And so we'll kind of go over 7 use cases or applications that I'm seeing increased interest and adoption in particularly for behavioral health. So the big problem here is that life happens for our patients and for our clients when they're not right in front of us. And that really creates a lot of gaps in healthcare. So we're typically really good at doing treatment and intervening when patients are right in front of us. That's why we have appointments, we have groups, we have individual sessions, we have all these interactions, but really 80% of outcomes, or what predicts 80% of outcomes long-term, is actually not what happens in session or during a live interaction. It's what's happening outside of those interactions. Everything that creates or everything that is life for our patients and clients. And that's something we just don't have a lot of insight and visibility into unless they're inpatient. We're with them all the time. But in an outpatient setting is really when they discharge from inpatient settings. There's a lot going on. And really what makes that patient a person, what drives them, what are their obstacles, everything that makes them human, that whole person, we don't actually have a lot of insight into when they're not right in front of us. And that actually creates a lot of gaps. That means that we, in order to get some of that information, that patient generated information, and really understand what their state is, we have to bring them into the office. And that creates a lot of wait lists. So the average wait time right now is 5 to 6 weeks. I hear it's actually way more than that. That's just the published. We're seeing an increase in depression and anxiety, and just overall less and less people being able to seek care. We're also getting a lot of burnout, a lot of people leaving, a lot of providers leaving, a lot of them having less ability to see more patients. And that's pushing a lot of patients to like even primary care. So now you go to your primary care physician, 70% of PCP visits are now in part behavioral health related. and meanwhile, we're still having wait lists in our inpatient and outpatient settings. And we're not adding clinicians as quickly as we're losing clinicians. And that's particularly the case for psychiatry and psychology, a little bit less so, but still present for social workers, marriage and family therapists, licensed professional counselors, things of that sort. So all in all, we're getting more demand, less capacity to meet the demand, and we only really have great insight when they're right in front of us. If we were to actually do preventative care as recommended, as guidelines, it would actually take more hours in a day for us to see the patients and give them the attention that they need. So there's really just no way to do this without starting to leverage technology. If we kind of just keep with the traditional face-to-face, person-to-person, there's just too much to do, too many people to see, and not enough people to do it, and not enough hours. So in the industry, we started saying, okay, well, what can we do? What should we do? How can we start solving this problem? Because it's been around for a while, and it's only exacerbated during the pandemic, and it's starting to still level out as a huge gap in ability to meet the demand. So technology-wise, there's kind of four main areas of what I would call healthcare interactions or technology-based interactions. We saw during the pandemic a huge increase in just telehealth visits. So that's what are called live technology interactions. So that's just kind of like we're meeting now, like a Zoom or some sort of telehealth, but you still have to be live with the patient. The provider has to have it in their schedule and available and live. Patient has to be available in their schedule and live, and a live interaction. So it solved the problem of having to require somebody to come into the office, and we can kind of move through sessions a little bit quicker, but still the same time capacity. And then there's this idea of what are called asynchronous visits. Now, traditionally, those have been done between provider and provider. So after you've seen a provider, seen a patient, then they'll do a consult, for example, and send over some lab work or some notes over to a colleague. And it's kind of been done asynchronously via email, text message, secure text messages, things of that sort. But really hadn't been applied to the patient-provider interaction. And then we started getting into remote patient monitoring. So devices that will, let's say if you have a heart problem or diabetes, you have a glucometer or an oximeter at home, giving live feeds of what's going on certain metrics back to your provider. And that works for conditions that have like a single metric, like I said, an oximeter or a glucometer. For behavioral health, that doesn't really work because there's no single metric for emotional health or mental health or behavioral health. There's so much going on emotionally and behaviorally. But it did kind of get at this asynchronous interaction between a patient and provider. And then there's mobile health, which is just, here's some resources, here's some information. You scored high on a survey, so we're going to send you a packet of information. And then we kind of digitize that into apps and different things, but really more towards self-care. So that's kind of the landscape of what we're doing with technology across healthcare. AI starts to really get into that and a little bit more sophisticated. So here's an overview of kind of AI solutions in general. We kind of see things from diagnostics and treatment, so really what's called clinical decision support tools. So things that are data mining in EHR or taking a diagnosis and giving a provider or clinician recommendations on treatment pathways or treatment types. Symptom trackers, where we're trying to get more touch points on what's going on with patients and their symptomatology beyond what they're self-reporting. There's computer vision, so this is where people are doing like AI-powered analysis of X-rays and radiology to detect cancer, workflows taking what's going on in a hospital and trying to find efficiencies, risk stratification, so taking a whole population health management and saying who's at risk the most. across many metrics, and AI can then start to say, okay, these are the people who are likely to cost the most or end up in the ER, things of that sort. And you can kind of see just this spattering of how AI is being applied across healthcare, even to the extent here on the top right, even just matching engines of like patients who would do better with certain types of providers, and apps that will help keep patients engaged. So you can see a lot going on right now, and that's only accelerated over the last couple of years as we've really seen a huge increase in really the technology and the power behind AI. For a long time, AI wasn't being adopted. Everyone in healthcare was pretty hesitant to adopt AI. And through the pandemic, everyone kind of saw, or most people saw that, okay, we're going to really have to adopt technology and adopt AI. And then, of course, there's ChatGPT that kind of really knocked down another wall, and people have a little bit more familiarity, a little less hesitancy, and kind of saying, hey, AI can be used for good. A lot of the AI stories prior to that were AI being wrong or leading to a poor outcome. And so there was a lot of distrust there and a lot of misunderstanding. So ChatGPT was definitely the first generative AI that kind of hit mainstream and a lot of people using it on a day-to-day. And so we've seen a lot of those barriers be lessened or removed as we've seen that. Do see a question. Let me see. In regards to the data processor to machine. Yeah, let's get to that, Scott, a little bit later. The question is around AI data reinforced machine learning and how to approach that using PHI. And so let's definitely talk about that here in a little bit. Thanks for that question. So that's what's happening across the industry. In behavioral health, I'd say we're a little bit behind compared to the rest of medical and healthcare, which is pretty typical. Behavioral health was slower to adopt EHRs when they were first coming out. Behavioral health was slower to adopt telehealth when it was first coming out. And then everyone was forced to do it during the pandemic. So in general, behavioral health is focused on kind of these areas in terms of technology. So when it comes to patient-generated data, so we do a lot of patient intake assessment. So most of the data we get for an episode of care comes in the first 24 to 7 days of treatment. We're doing biopsychosocials, we're doing intake assessments, we're doing lots of evaluations, psych evals, mental health assessments, and we use all of that to drive the rest of treatment. Now, we do have clinical notes and group notes and things that do help us course correct during treatment, but the bulk of the data collection is done at the beginning. In outpatient settings, we started to see more patient engagement, text-based things, as well as like phone calls, case managers, care managers, trying to keep patients connected. And then, of course, telehealth platforms, we're using those a lot more. And then we've always done outcomes tracking. I would always is relative. I'd say for a long time, we've done outcomes tracking, but primarily focused on multiple choice standardized measures. And those give us a quantitative outcome, but really don't tell us much about what's going on for the patient that drove that score. Why did they score themselves that way? And what's going on underneath all of that? And so while behavioral health is behind a little bit in adoption of AI, even more so behind in the adoption of just technology in general, although we are getting better. So that really leads to this idea of like, okay, what are we doing? What are the emerging solutions to address this problem? A lot of people need care, not a lot of us to do it. The ones that we do have in our care, we actually have less visibility when they're not right in front of us, so we force all these live interactions. So really, what do we do to to solve that. And this really where it comes into like voice and video. So for 5 to 8 years that we've had this push in voice analytics. So there's lots of research out there now around using voice biomarkers. Can we detect depression, anxiety off of voice? Can we actually detect that when we combine voice and digital phenotyping, which is how they're interacting with social media, how they're interacting with other technologies? And we found that there are idiosyncrasies, there are patterns, there are differences for people experiencing mental health issues and how they talk, how they present, and how they interact with technology. And now we're starting to see a shift towards not just, okay, let's use technology like text, phone calls, text, mobile apps, to, well, let's analyze some voice and see if that can tell us. And now we're really like, okay, well, what more can we get? Well, we can get some out of voice, but by adding video, so having recorded video clips of patients and analyzing that in addition to the voice, as this researcher found, will help better characterize the patients. So like I've said, and this is a motto I say a lot, is like, well, what makes that patient a person? What makes that client a human? And that's really what we have to get at if we're going to really leverage technology beyond just documentation or workflow, but technology for the human, technology for the patient that's going to help them. We really have to get beyond just voice. And here's another quote from Dr. El-Kaloubi, who is considered the mother of emotion AI, wrote the book on it. A good friend of mine sits on the board of my company, and she said this, which I think really hits at where AI applies to behavioral health. She said an emotion AI world is a human-centric world. So again, that focus on the patient, not on our operations or helping the provider. And it's one where technology has our backs, helps us become healthier, happier, and more empathic individuals. And really, I think that's my goal, my mission as a clinician, by background as a psychologist, and now in kind of technology entrepreneurship and software development, to really make technology and AI empowering to providers and meaningful for patients. How can we really understand what's going on at the human level to increase our outcomes? So I kind of want to do a little bit of an activity here. So I want to pose this question, and if you could drop some things in the chat of when you are interacting. I'm assuming we have some clinicians on the call or administrators, staffers, whatever it is, as you're interacting with clients or patients. What are you looking for and what are you listening for as you're interacting with patients? For clinicians, you know, that might be something that you're thinking clinically. For staff, you might be assessing or evaluating how they're doing. What is it that you're looking for and listening for? So somebody said body language, tone of voice, rate and tone of speech. Somebody else said tone of voice, general appearance, body language. Symptoms of depression, congruence. One common thing we say is their affect congruent with the content of their speech? Is what they're saying matching what they look like? Yes, these are the things that we are generally looking for, listening for as we're interacting with our patients and clients. As humans, we can usually try to track about 5 to 7 of those at any given time. Oh yeah, some more: emotional awareness, lack of insight, avoidance, activation. Yes, these things that that we use as data points to decide what type of interaction or intervention or treatment is needed. Now, as humans, we can kind of track 5 to 7 of those in a given interaction, and then we typically can compare that to maybe 1 to 3 previous interactions. So if I know, let's just say Nicole talks like and sounds like and looks like this, I can kind of compare that to the last couple of interactions, but beyond that, humans were actually, we don't compare super well. So what this, why this is meaningful is a lot of these things is something we can teach a computer to look for and listen for. Something like rate of speech, how many words they are saying per minute, we can transcribe what's said and calculate very accurately how many words they said in a minute. And we can compare that not only the last couple of interactions, but all-time comparison to any time we've ever had that patient on video. And then it gets beyond just what we call descriptive AI, which is the rate of speech, things like absolutist language, word complexity, and we really get into emotion. We can start trying to pick up on those things that we look for and listen for in their tone of voice, in their body language, in what they're saying and how they're saying it. And now all of a sudden we say, okay, if we can teach a computer to look and listen for those same things we would do in a patient interaction, and in many ways it's more accurate, and it can compare to past interactions and compare to baseline better than we can, then all of a sudden we have this opportunity to really scale our interactions. Now there's going to be a need for still a patient-provider interaction. There's things that humans can uniquely do that machines can't do, and that's treatment. However, we spend about 40 to 50% of our treatment time actually just gathering this type of data, just trying to have the interaction with the patient enough that we have a good understanding of what they look like, what they talk like, what we're looking for and listening for in order to have that intervention. And that's something we can leverage AI. So what this looks like, so this really gets into the video component of it. So here's an example. If we can get 30 seconds of a recording of a patient responding to any sort of prompt that we might ask, like in a clinical interview, like, in the past 2 weeks, have you felt this? Or what's been going well? What's been not going well? We can do a couple buckets of types of AI. We can do natural language processing, so we can analyze what they said and how that differs from a normal population, quote unquote normal population. We can do voice analysis, so not just what they said, but how they said it, and then compare that against their own individual baseline as well as against a population baseline. We can do facial analysis. So again, back to what one of the comments was in the chat, is what they're saying and how they're saying congruent to how they're presenting. And we can also do movement analysis in terms of, are they having twitches, jitters, movements, kind of more of that body language. And all of a sudden we can replicate in part what would be an interaction with a live provider, but we can do that at scale to thousands and thousands of people at any given time. And then once we have all of that information, now we have this qualitative analyzed information, we've quantified it, we can start to understand what somebody's state is. We can detect suicidal language, emotional distress, whether they're increasing or decreasing in depression or anxiety, or if they just need help scheduling a visit, really understanding what's going on for the patient. In order to do that, we have to make it easy. And I say we in terms of the industry as a whole. We've, for a long time, sent a lot of surveys. And surveys can get long. And if we want to do a clinical assessment, like I'm a psychologist, so I would do a psych eval, and I would spend 3 to 6 hours with patients just gathering information before really formulating a treatment plan. So we have to really meet patients where they're at. Oftentimes when we're available during the workday in an outpatient setting, they're also at work. So they're not going to pick up my call. I may try to email or text, but I'm getting limited information there. So now we're seeing in the industry this idea of an asynchronous video interaction or an asynchronous video assessment, which is a way to send a patient a link, and whenever it's convenient for them, they can click that link and be guided through basically a clinical interaction. Be asked the same questions that we would ask them if we were in the room with them, record their answer, submit that video recording, and then, as I just showed, then the AI technology now exists to then teach a computer and machine learning to look for and listen for those same things. And then we can make all that available to care teams, from summaries to risk stratification, who's doing well, who needs intervention now, who's going to end up in the ER, who's okay for a couple more weeks without a session. Therefore, we can get the people who are in crisis into our schedule and really get this longitudinal view. Now, you've all seen an outcomes longitudinal view just like this. However, this is including emotional data. This is including some of those things that we look for and listen for if they were right in front of us. So really the power of AI in behavioral health is beyond some of those workflow and diagnostics, and really, what are people saying? How are people saying it? What do they look like? What's going on in their body language? And how can we use that to affect treatment in real time, as well as influence short-term and long-term outcomes. So want to spend the rest of our time talking a little bit about these applications in behavioral health. But before I do, just want to pause real quick to see if, Nicole, if we have any questions additional questions we want to answer now.
We just have that question from,
okay.
Yeah.
So let me go through some of these applications, and we can get to this some of these questions here at the end. So one of the first applications of behavioral health is, as Nicole mentioned, is this idea of replicating. Can we get more information out of one interaction? So for example, if you go give blood at a primary care physician for lab work, they're going to take one vial of blood and they're going to go run 20 tests off of that one vial. In behavioral health, we're still doing this thing where we're going to give you one survey that gives you one outcome. And if I want another test, I have to give you a different test. So there's been some research around how do we take what was a PHQ-9, for example, which is 10 questions, and how do we really get at what's going on beyond that? So here's an example of the PHQ-9. The 9th question is a suicidal question. And the 10th question that often people don't even administer is an open-ended question that says, if you checked off any of these problems, please explain how difficult that's made for you. How's it impacted your life, basically? So we did this experiment where we gave people the PHQ-9 traditional, and then we actually turned that 10th question into a video response and have 4,000 patients respond on video. And what we were able to find is that people were actually, in this case, you can see that he put not at all having thoughts of hurting myself, but actually when you gave him a moment to actually explain what was going on, he was actually having suicidal ideation. But it didn't quite fit the exact prompt from the PHQ-9. So then what we did is we took that, all those videos, and we said, hey, can we predict somebody's PHQ-9 score just off of 30 seconds of video? Turns out we can. Within a 2-point to 3-point accuracy, 91% accuracy, we can predict what somebody's PHQ-9 score would be without administering the whole survey and just getting about 30 seconds off of video, which is really powerful. So now you're saving time. It's a better patient experience. They're going to actually, what we found was when you give patients a minute to talk, they actually tell you a lot. On a survey, they only tell you what they're being asked. For those data-driven people in the room, here's a little bit of how that works. In short, this is saying the AI algorithm is very accurate at predicting somebody's PHQ score just off of a video recording. And what we did then was we did that again for the GAD, which is the anxiety, and then we did it also for the PCL, which is trauma. And so in each one, from 30 seconds of video, we can predict what their score would be. And then we went in and said, well, what if we go back into that vial of blood example? Well, what if we just got one 30-second clip rather than three 30-second clips? And what would we need to prompt in order to predict all scores? And so we did another 4,000 patients and realized with one well-crafted prompt, we can get one 30-second video clip and predict all 3 scores with 90% accuracy. So now we're getting really at that lab type of example of with one test, with one interaction, we can actually predict multiple things. So these are what are called predictive AI. So these 3 scores are predictive AI. And then in addition to that, we're getting all of that descriptive AI we discussed earlier, all of the rate of speech, sentiment, affect, emotional analysis, word complexity, about 40 biomarkers plus the predictive scores just off of 1 30-second video. And again, very accurate. And we'll kind of skip through this. So then we kind of get into a specific use case of addiction and relapse. So okay, if we know that relapse is common and often, unfortunately. And so if we can learn this about humans, about patients, how can that be applied to prevent or predict relapse? So what we did was some research. We took a bunch of EHR data and video data and combined it and said, well, what can we learn and what can AI learn about what predicts relapse? And what we found was that a combination of quantitative, which is kind of what's in the EHR data, and qualitative, what's in the video component, we can accurately predict somebody's sobriety status at 6 months and 1 year, how many days clean they're likely to stay clean if they were to discharge today, as well as the likelihood that they would complete treatment. And so all of a sudden we have some very powerful algorithms that can give us a lot of insight into what's going on with patients. And we can even get that down into like what's the most powerful predictor within that. Interestingly enough, the nursing notes, and this data came from about 10 years worth of data at a residential substance abuse recovery program. What was being documented in the nursing note actually predicted discharge disposition or likelihood of completing treatment better than any other note in the EHR. We also saw that these are confidence intervals for different medications. And I kind of blurred some of this out because it was specific data to this data set. But I will say that top one was, we found that if somebody had been prescribed melatonin during treatment, they had a higher likelihood of completing treatment, which actually kind of makes intuitive sense. Like we think of just the power and importance of good sleep in order to really engage in treatment. And so we kind of start to AI can really extract some information and analytics that we wouldn't maybe have thought of. We can also do what we call live video analysis. So this doesn't get at much of the asynchronous nature, but let's just say you have a recorded Zoom session or you have a recorded group session, and how can we improve that interaction? So we did some interaction analysis that analyzed the emotion of both parties, from the provider and the patient, what the interaction was like, and what language they were using. So this is an example of an analysis of this top kind of darker blue is how much the provider talked. This kind of pink salmon is how much the patient talked. And then these blue on the top and bottom is when either the provider or the patient asked a question. So you can see at this top session, the provider really dominated the whole session. Patients not speaking a lot, asking some questions, and the provider is responding, which is great, but really responding at length and not giving a lot of time for the patient to respond. In contrast, you can see that the bottom session, the session was fairly equal. The provider taking up 51% of the speaking time, and the patient taking 49% of the speaking time, and somewhat provider asking a few more questions than the patient, but giving the patient opportunity to really respond. And so we can use this data in a way to, again, improve some of that interaction with between the provider and the patient. We can also see what kind of pronoun usage they're using. Now, pronoun, I mean in terms of first and second and third person. Research has suggested the more pronoun usage that is personable predicts better outcomes. And so as much as we can use that type of language is helpful. We also get to this idea of like, people have brought up, well, if we record sessions, how can I get a quick summary of that session? We're thinking like BestNotes or so.Dr. How can I take a 40-minute interaction and really get a quick summary? If I wasn't the one in the session, or even if I was, how can I quickly summarize what was important and what wasn't important? Even at a 40-50-minute session, when we kind of go to write a note and look back at what was said, we're actually have what's called selection bias of like, we only remember certain things in certain orders. The primacy and recency effect even influence how we write our notes. So how can we actually use AI to quickly summarize a whole interaction and what is most important? And so we took about 60 video transcripts. We put them through generative RLHF. So this gets back to one of the questions, Scott, you had, is data and reinforced machine learning. So we took transcripts, we taught the AI to summarize it, and then we had the clinicians go through and say whether that was an accurate or inaccurate summary of what happened in the session, and that's how we trained the model. And for those not familiar with that term in the room, that means we're really reinforcing the training of the AI and of the algorithm with clinical ratings. So we can take something as simple as this video transcript and make a session summary. So now you can have a system or a platform reach out to 1,000 people this week, ask them how they're doing, what's going well this week, what's not going well this week, get 30 seconds of video, and get all that prediction that we talked about from descriptive and predictive AI, and get a quick summary of what's going on. So if somebody triggers an alert, we can say, okay, somebody's in emotional distress. Well, why are they in emotional distress? And we can quickly look at a session summary and immediately know what they're dealing with, what's driving it. And now we can know of those 1,000 people, here are the 20 that we need to focus on and what's going on with them and what's driving it before we even reach out. And that really gets into some of the more high risk situations, like how do you identify people in distress or suicidal? I think I saw one question come through around legal battles, which we'll get to a little bit more in detail. But that's one of the common questions we hear around application of AI in behavioral health, was like, well, what if somebody's suicidal? And what do we do there? Of course, there's risk. My common answer is no more risk than us having a voicemail that people can call and leave a message, or email us, and we're not necessarily going to say. So we often put disclaimers on that voicemail and on our email. Our voicemail saying you've reached the confidential voicemail of Dr. Brett Talbot. If you're in an emergency, call 911, call 988. Otherwise, leave a message. I'll get back to you as soon as I can. We put all the disclaimers at the bottom of our emails. If you're in an emergency, I may not get back to this. And so these types of asynchronous video interactions are similar to that. Yes, there's risk that somebody might say something suicidal and we may not see it, but no more risk than those. And if we didn't have any of those available, that doesn't necessarily mean that they're not suicidal. That just means they're suicidal and nobody knows. So this at least allows us to surface those that may be, and at least make it visible and actionable, and then we do our best to take action. Now, that's not quite good enough for me. So then we started thinking like, well, how can we teach AI to trigger that quicker? And so we started taking these video transcripts and what people are saying and how they're saying it, and the emotional analysis, and how to really differentiate between if somebody was distressed versus if somebody's suicidal. So we start seeing a lot of that because we're concerned about legal. we actually kind of lower the threshold, which is good in clinical practice. Like if somebody has suicidal ideation, we're going to start to intervene early, which is good. But sometimes that might just be distress, but we're just not sure yet until we actually get them in front of a clinician, do an interview, do a Columbia risk assessment. Like it actually takes quite a bit of work to differentiate if somebody's distressed or suicidal. So we took all of that and trained an algorithm to try to differentiate between emotional distress and suicidal language, again, through that human and clinician reinforced. And we actually we can detect whether somebody's distressed or suicidal. And if somebody is suicidal, then we can start triggering alerts and getting them over to a call center. Somebody can reach out, or just routing them immediately to a 911 or a 988. And that's actually what we call like a hot touch, meaning like we can actually get them to take action now, versus some of that email and voicemail prompts. It's like, if you're in an emergency, you take the initiative. You be proactive and call somebody. And the reality is, a lot of them aren't going to do that. And so if we can analyze this and really automate the warm handoff, we're more likely to intervene, be able to intervene in real time. But we have to know whether they're distressed or suicidal, or we're just going to start sending everyone to, to the hotline. And lastly, before we get to some Q&A, this is related to behavioral health in the sense that if you're not familiar with this disease state, tardive dyskinesia, it's a movement disorder that comes from either overprescription or overdosage, or being on a psychotropic medication for a long time. So they're being treated. Psychotropics are being used to treat schizophrenia, bipolar, and if you've been on them for a long time or a slightly higher dose, you have this risk of developing this movement disorder that looks like Parkinson's or Huntington's disease. And if you don't catch it early enough, it becomes irreversible. So there's this huge need to assess at scale some of these very nuanced movement disorder or movements in the face and in the voice before it becomes irreversible. And so similarly, we took some of these videos and we taught an AI. There's a traditional method called the AIMS, where you have to get the patient in front of a provider who's trained in administering the AIMS assessment. Takes 20 to 40 minutes to do. And we've taught a computer to look and listen for those same things that the AIMS would, and we can now detect early signs of tardive dyskinesia with only about a 3-minute interaction. And that does not require a clinician on the other end. So this can be done asynchronously at scale in only about 3 to 5 minutes, rather than a 20 to 40 minute assessment with a live provider. So you can kind of start to see the application of like all the way from just how are you doing and descriptive and emotional analysis to predictive analysis and their likelihood of increasing or decreasing, as well as side effects of medications and other symptomatology that we can pick up on video that we traditionally had to have a clinician in the room to do it. And again, those data geeks in the room, highly accurate in terms of being able to assess that via asynchronous video only. In general, the use of video assessments, the use of video and voice AI is rapidly growing. We're seeing it in behavioral health across depression, anxiety, trauma, substance use, even SDOH. So those are the social determinants of health. What's impeding somebody from getting treatment? Do they have transportation? Do they have food insecurity? Do they have housing? And oftentimes those are not being assessed unless we give yet another specific multiple choice question. But we can actually start to pick up on some of those things if we just give open-ended prompts that just allow a patient to really just talk about what's going on. And now we can pick up on a lot of things. Video assessments are now being recognized by the FDA. I mentioned the clinical decision support tools. So there's still a lot of AI ethics. It's still a little bit Wild West, but there's now becoming more ethics and guidelines. And the FDA is starting to say, okay, here's where we'll allow AI to make decisions and not make decisions. So for example, video assessments are not allowed to diagnose yet, but they are allowed to say, out of 1,000 people, if you're concerned about depression or anxiety or trauma or suicidal or tardive dyskinesia, here are the people who you should look at first. Being able to scale that type of interaction is super powerful. We're seeing it being used across military, inpatient and outpatient behavioral health clinicians, pharmaceutical companies, community health, hospitals, and large payers are even now starting to adopt, and insurers are starting to adopt these type of asynchronous video interactions because they want to know what's going on with the whole population, know who needs what when, and in the end will save them money, but also it'll get patients the right care at the right time. And so we're starting to see the increased rate at adoption of these types of AI solutions in the market. The future really looks like beyond this prediction, beyond some of these clinical decision support and assessment tools, really getting to predict disease state, really getting to the point of where we can diagnose based off of video. And then really, if we can do that, really automating some type of treatment. I still believe that there's going to be a component or a portion of the population that needs human engagement, needs human and clinical treatment, and that will be reserved for the high acuity. But those who are kind of in the mild and moderate, maybe have had an intense episode of care, but now we're kind of in transition or in between, or trying to titrate back to a normal kind of normal life, we can start to automate a lot of that. If AI can continuously or consistently touch base, assess, and then deliver some sort of mild to moderate treatment pathway. And that's really where AI is going to be going in the near future. So with that said, let's kind of go back over here to some Q&A. It looks like we have a couple here. So the first one is, as you've said, AI can learn to detect some symptoms or patterns. I think you meant better than humans. Do you see a future where AI dependent, or at least AI assisted diagnosis becomes common? Yes, actually, good segue from what I just said. Absolutely. I think AI assisted diagnosis is like in the near future. We actually have at my software company have a couple algorithms that are very close to being able to get to that. I think the FDA and kind of AI ethical guidelines are kind of what's hampering innovation right now. So as soon as we can get that figured out at a federal level, then I think you'll see a massive rush for people seeking 510(k) clearance, which is the FDA class 1, class 2 clearance to have AI diagnose, or at least AI assisted diagnostics. So I think that will become common and soon. Are you concerned about the ongoing legal battles regarding AI in the creative space? Would negative rulings in the sphere noticeably affect the use in healthcare? Yeah, I would assume you mean some things going around with screenwriters, movies, AI replicating singers' voices, things of that sort. Yeah, I think, again, we're still trying to figure out at a federal level and across industries where we're going to allow AI to be a part of our narrative, and where not to. I think that's still the case in maybe medicine's a little bit further ahead, but especially in behavioral healthcare, we're still trying to figure that out. And of course, negative rulings may affect exactly how we use, for example, PHI, somebody's individual PHI to predict a disease state. And of course, that comes down to a lot of informed consent, privacy policies. Do they know how we're going to use their data or their video data when they provide it? I maybe I'm optimistic, but I think that, going back to Dr. Kaloubi's quote, that I think as people realize AI and machine learning and technology isn't just Big Brother and Minority Report trying to like catch you before you commit a crime. Like this really is about you and about getting you to be the healthy you as quick as possible, and really reducing the amount of healthcare waste we have in order to, and trial and error in order to get you healthy. All of these things help you and help us get you better quicker. And as once we get to that, I think there won't be as many legal issues or resistance. Could we get an example of personal pronoun usage in session? Yeah, I think what I meant by that, this particular study was with a children's hospital. And what they found was that when they got sued as a hospital, they mostly got sued because of negative interactions between the provider and the patient. But what they found was that if the patient had a good relationship with the provider, then they were less likely to litigate. They were less likely to sue. So then there was this huge focus on like, okay, how can we get providers and surgeons who are sometimes therapists, maybe a little bit more personal, but these were surgeons, these were psychiatrists doing med changes that weren't necessarily doing full sessions with these patients. They found that if they could get that provider-patient interaction to be personable and good, then even if something bad happened, the family was less likely to sue. So an example would be like, I'm helping you versus the hospital is this. Like removing the provider from the relationship, which is something that a lot of providers are taught to do, because hey, like you're doing treatment, like just make it about between the hospital and the patient, you're just kind of facilitating it. But if you can actually navigate that better, then you're less likely to get sued. Do you see this as a billable to insurance at some point in the future? Actually, not just sometime in the future, now. Some of our customers have actually had been successful in being able to get reimbursed. There's a couple reimbursement code sets. So there's what's called remote patient monitoring. There's also remote therapeutic monitoring, behavioral health integration codes, and chronic care management codes. All of them have had some success in being able to get reimbursed for these types of asynchronous interactions. The problem is that it's a moving target. Every year, CMS comes out and moves the target and changes the rules. And then commercial payers, the Blues, the Aetnas, the Selects, whatever it is, then kind of use those guidelines, but make their own rules as well. They make their own guidelines. So it's a massively moving target and changing. So the consistency of reimbursement is not there yet, but we are seeing an adoption or an increase in getting reimbursed even now. And then let's see, many people are AI phobic, or at least AI concerned. As the industry moves in this direction, how do you think these people will be served? Will there be people who don't seek help because they don't want the computers to read them? Will providers allow an opt-out, or will there be a niche market for old-fashioned therapy? 100%. Look, there's a portion of our population, of our patient population, that won't do anything we say. If we have them live in the hospital, strapped to bed, it doesn't matter. They're not going to do anything. So there's going to be people who aren't going to comply. I do think that there's going to be a transition. I think the younger generation is more quick to adopt. I think the older generation is quicker to adopt the technology, but not trust the AI yet. And I think that will just come with time. But I do think there will always be a need for, just as you call it, old-fashioned face-to-face. But I think we'll see a quicker adoption or an increased adoption for technology and AI in the near future and over time. I think we're just about time. I have a few more minutes to answer any other questions, or back to you, Nicole.
Yeah, thank you, Brett. Thank you for this webinar. I'm curious, outside of your product, do you use AI in any other aspect of your business?
So there is some application. So we use it a little bit for our own staff, as like, especially during pandemic when everyone was remote, we were actually having our own staff check in weekly on our system so that we knew how people were doing. And actually that grew into a couple what we call employer use cases, where we were doing daily video check-ins for employers that had 10,000 employees during the pandemic. So the system was not just checking on, are you okay? Do you feel like you have what you need to do your job today? But also, like, are you having any symptoms? Are you COVID positive? Are these sort of things? So beyond just healthcare, just employees, and just how are you doing? What do you need for to be successful at your job? We started to see that emotional, like just those types of check-ins. We weren't doing the same amount of clinical analytics on those video check-ins, but just the emotional analysis was meaningful. And so you just knew how your workforce was doing. That's kind of tapered a little bit now that we're kind of back in office a little bit more. But during the pandemic, when everyone was just remote, we were doing, I'd say, between 5,000 to 10,000 employee check-ins a month.
Well, thank you so much for this presentation, Dr. Talbot. This is wonderful, and I appreciate you sharing your insights and answering all of our questions on AI and behavioral health. For those of you who would like to stay connected with Dr. Talbot, I dropped a few links where you can follow him. Please check out his LinkedIn as well as his official company website, federahealth.com. Dr. Talbot, do you want to share an email address where people could ask you questions?
Absolutely. Let me drop that into the chat right there as well. Find me on any digital medium you see convenient and preferable to you, but happy to discuss any other questions, comments, concerns about AI. If you're thinking about how to apply AI into your practice or into your environment, let me know. And if I can't answer that question for you, I'll try to find somebody who can.
Well, thank you everyone for being here today. We are going to post this recording on our login screen, the BestNotes login screen, and we will of course send out a copy of this webinar to registrants. So for now, everyone enjoy your day. Thank you.
Appreciate everyone's time.